Hi, everyone, and I want to welcome you to our panel discussion on long COVID's impact on the workforce. I'm Scott Modello, Medical Director for the New York State Insurance Fund, or NYSIF. And as you're going to hear about in a minute, NYSIF released a report on long COVID earlier this year. Our goal today is to provide a more in-depth conversation of long COVID, how it affects people's daily lives, especially their work life. And ultimately, we would like to help employers understand how to support their workers with long COVID. And hopefully, we'll be able to provide some specific strategies that businesses can use to support and retain employees with long COVID. And with that, I'm going to introduce our wonderful group of panelists. And I'm going to start with our own Executive Director and CEO, Gaurav Vashisht, who's part of our New York State Insurance Fund. He's our leader. And we also have Dr. Navneet Kathuria. He's a member of NYSIF's Board of Commissioners, and today he's also going to serve as a moderator for our panel discussion. We also have Commissioner James McDonald, who is the New York State Commissioner of Health, and we're very happy that he was able to join us today. We have Dr. David Petrino. He's the Director of Rehabilitation Innovation at Mount Sinai Health System, and he's a professor of rehabilitation medicine within the Icahn School of Medicine at Mount Sinai. We have Dr. David Cutler, who is the Otto Eckstein Professor of Applied Economics in the Department of Economics at Harvard University, and he also holds appointments at Harvard's Kennedy School of Government and the School of Public Health. We have Nisha McCrae, who's the Executive Director of a nonprofit organization, Bagika, that focuses on making STEM education, so science, tech, engineering, mathematics, education accessible to people of all ages and backgrounds. But also important, she's a person that's living with long COVID and serves as an advocate dedicated to raising awareness of long COVID. We also have Dr. Franma Bu, who is a senior research associate at the Urban Institute. She's housed in the Income and Benefits Policy Center, where she is a member of the Building America's Workforce Cross-Center Initiative, and she's affiliated with the Office of Race and Equity Research. And last, certainly not least, we have Dr. Sarah Von Schrouder, who's the Director of Research and Program Evaluation for the K. Lisa Yang and Hockey Tan Institute on Employment and Disability in the School of Industrial and Labor Relations at Cornell University. And with that, I want to turn things over to Gaurav to help get the discussion started.
Thank you, Scott, and good morning and welcome everyone to NYSIF's conference on long COVID, a much needed conversation on a complex topic that I'm sure will be highly informative and enriching for all of us. My name is Gaurav Vashisht, and I am the Executive Director and CEO of the New York State Insurance Fund. By way of background, NYSIF is the largest workers' compensation insurance company in New York State. It also ranks among the top 10 nationwide. It's an organization that's more than a century old, deeply rooted in labor, in particular in the labor movement of the early 20th century, when it emerged from the ashes of the Triangle Shirtwaist Factory fire. Unlike private sector insurance companies, NYSIF is a public entity that's established in law. Unlike state entities, NYSIF is funded entirely by premium income and investment income and not taxpayer dollars. In January of this year, NYSIF published a report on long COVID, analyzing its own claims data. The inspiration for this work was our public purpose as enshrined in statute, our history, and a realization that we collect information in the regular course of business that could inform the big picture on long COVID, an emerging public health crisis emanating from the pandemic. The conclusions of our report are significant. First, long COVID is real. Roughly 1/3 of those who filed an established COVID-19 claim with NYSIF met our criteria for long COVID, suffering to varying degrees and for different timeframes. Those who were infected during the most acute early phase of the pandemic, the novel coronavirus phase, before vaccines were available, were more likely to develop long COVID. Many were unable to return to work for more than a year. And while others returned sooner, they often did so while reeling from symptoms. The report also found that women and older adults were more vulnerable to long COVID than younger men, and those with comorbidities or those who were hospitalized for their initial infection were at much higher risk. These were the findings of our report, but the implications are vast and very important. For households and individuals, prolonged periods of unemployment means a loss of income, loss of employer-provided health insurance, medical skepticism, being bounced around from specialist to specialist, not knowing what's wrong with you, stigma, both personal and professional, self-doubt. For employers, it means dealing with greater requests for accommodations, reduced hours, productivity issues, challenges with reintegration into the workforce. And for the labor market, I believe the findings are significant enough to warrant a further consideration or continuing consideration of how long COVID may have and may still be affecting the labor participation rate. Our work has inspired us to continue exploring the impact of long COVID. We're pleased to facilitate this dialogue today. We're honored to have such a distinguished group of panelists participating with us today. Thank you all for your participation. And with that, I'm going to hand things off to Dr. Kathuria, my colleague, to take this conversation forward. Thank you.
Great. Thank you, Gaurav. Thank you, Scott, and good morning, all. And I just want to echo many of the things that Gaurav and Scott stated with regards to the long history of this organization and its public mission. And I think this effort with regards to better understanding the individuals that we support through our insurance and disability benefits is indeed very much in line with adding to the wealth of knowledge that this organization can contribute to. My pleasure to kind of assist in moderating this truly multidisciplinary panel that we have with us. We have folks such as Dr. McDonald from the Department of Health. We have Dr. Cutler from the economics background. We have an advocate. We have researchers. We have clinician scientists. So it is indeed truly a multidisciplinary group, and I'm honored to help assist in this moderation. Lastly, as a physician who is working in New York City, working in underserved communities, I saw firsthand not just the acute impact of COVID, but over time begin to see the long-term impact with colleagues who are on the front line, with family members, with patients. And I think it's truly remarkable that the attention that needs to be paid to long COVID has not gotten the attention that I think it deserves, and this is indeed a step in the right direction. I'm going to turn it over to our first speaker, Dr. James McDonald from the Department of Health, our Commissioner of Health for our New York State. Dr. McDonald?
Yeah, thank you so much. And it is great to be with you today. And it's interesting, like a lot of times when I give a talk about a topic, I try to give you a word. And sometimes I pick one word because I'm very cognizant that when you have a robust agenda, a lot of times people don't remember what people say, but you do remember a word. And I'm going to pick up a word that Gaurav has already used a couple times, which is the word significant. And I just want to throw this out there. When you think about the purpose of this conference, right, and you can together the intersection of long COVID and work, it's significant. When you think of the issue that you asked me to address, was the intersection of long COVID and health equity, it's significant. And one of the things I'll say about something that's significant, if something's significant, it doesn't mean it's fully known yet, though. And there are other things in our culture that are significant that just quite frankly aren't fully known. And long COVID, to me, is one of those. And as we talk a little bit about the intersection of long COVID and health equity, I wanted to just share 2 slides with you. Part of it, because sometimes we use these terms, health equity, we use the term social determinants of health, and we use the term health disparities, and I'm not always confident that we're talking about the same thing. So if you look right now, I should be sharing these 2 slides, and one of them says, in the bottom in the lower, it says New York Public Health Law, Article 2F, and that's the citation in statute. And I've abbreviated the definitions a little bit, but one of the things I want to make really clear is New York State actually defined what health equity is, what social determinants of health are, and what health disparities are in law for a reason. They were defined in law for a reason because it's nice to have a common understanding of these terms that, quite frankly, aren't core to everyone's culture. We didn't grow up with these words. And because we didn't grow up with these words, we don't know how to apply them to our lives all the time. When you hear people talking about health equity, I worry sometimes people are agreeing that it's important, but they don't know what they're agreeing to what it is. And so this is the definition: highest level of health for all people, and shall entail focused efforts to address avoidable inequalities. If you're part of the human experience, I hope you would agree, this is a good definition. By the way, we should want this for everybody. In other words, there's no reason why we all shouldn't want the highest level of health for all people, and to address avoidable inequalities. I think this gets back to that golden rule: do unto others as you want others to do unto you. We all would want the highest level of health. And when you look at social determinants of health, these are life-enhancing resources such as healthful foods, quality housing, that determine length and quality of life. Quite frankly, again, as you're part of the human experience, we should want this for all of us. And really, we don't need to live in a global experience where we compete for these things. Everybody should have these things. It's part of what should be part of the normal human experience. And regrettably, though, we deal with a world where there's a lot of health disparities. And particularly in this country and in this state, we have health disparities. In health disparities, though, we talk about, that's a measurable difference in health status, access to care. Quality of care is determined by race, ethnicity, sexual orientation, and other demographic differences. And one of the things I've said to the department is, when I talk to my team at the department is, we need to eliminate health disparities. And I know that may sound a little bit bold to say we need to eliminate health disparities, but if a state health commissioner isn't willing to commit to doing everything we can to eliminate health disparities, I'm not sure who would be. And a lot of times I just tell people on the department, our mission is, we're a health equity organization. We just happen to do public health. That's what we do here. And I think it's just important to have that context about who we are and what we do, because this is the core of what we do. And long COVID is really a big part of all this. And I did put a little slide together about long COVID. We have a webpage on long COVID, a webpage that's been developed and yet will be further developed. But really, it's just one of those things where it's a place to land for this. But one of the things that's interesting is I like in a way that some of the information is almost becoming outdated right away. Because one of the things it says in there is there's no test to diagnose long COVID. And I almost want to say there's no test to diagnose long COVID yet. I think some of you probably saw the article in Nature came out this week about a biomarker. This was thrilling for a lot of reasons. It's like, who gets thrilled about lab tests and science? Well, I do. Part of why it's thrilling, though, is it shows progress. It shows that we can actually find something. And I think we might find long COVID ends up being more of a collection of diseases. And quite frankly, that's significant. But quite frankly, it's one of those things where it's like, it's nice to have a test for something because it validates people. And it's sad. But one thing Rob said, I think it's so important and so true, is that sometimes people are going from doctor to doctor and being doubted. And that's not right. And that's just human nature. But that's not okay. And one of the things we have to accept is that it's a significant new disease, and it may be multifactorial, and it definitely has a large impact, but it's real. And I think one of the things I've seen when I look at the federal government is, I'm going to stop sharing my slides now because I just want to get back to you guys. But one of the things I'll just say is, when I look at the federal government, there's been a commitment, over $1 billion commitment. So there's research going on in our federal government. This is a global experience, though, right? In other words, the whole planet is struggling with long COVID, and we haven't seen this from other infectious diseases. We haven't seen this with rhinovirus or influenza virus or respiratory syncytial virus. So this is part of this new journey about dealing with this novel coronavirus, SARS-CoV-2. One of the thoughts I want to leave you with is, I talked about the word significant. I would suggest, though, that your very gathering today is significant. I love the way you're leading on this. One of the things I told Gaurav about was I'm excited that we made the connection we did. We're aligned organizations. We want the same things. He and I talked a little bit about where are areas we could partner. Where can we take our data, merge it with your data, create some intellectual work, and contribute to the world of science? And I think that's really important. Last note I'm going to leave you with is, the state health commissioners, does he always talk about the COVID vaccine? No, not always. Occasionally I talk about the Mets. But having said that, it does come up more often than you might imagine. And I'll just say this is, I want people to look long and hard at the COVID vaccine. And I realize the transition of the commercial market's been a little bit inelegant, but it's coming and it's here and people are getting it. And I'm concerned a little bit about access in the commercial market. I'm concerned a little bit about how it's going to impact communities that normally experience disparities. And we're doing what we can at our end. We don't have data to track, and that wasn't something we were granted by the legislature. So I'm a little concerned that we won't have the data, but I'm going to do what I can at the Department of Health standpoint to interact with federally qualified health centers, interact with community-based organizations, to do what we can to make sure the vaccine's available all over the state to everybody in the state, and really make it as much impact as possible with this. And one of the things I'll just say is, I think as I wind up my time with you here is, I think last year when you heard people talking about the COVID vaccine, it was almost this constant cajoling of people to get the vaccine. And that's just not me. I'm not going to be cajoling people to get the vaccine. I'm going to be saying, do me a favor, get the COVID vaccine. I mean, quite frankly, do yourself a favor. The vaccine's likely to keep you out of the hospital and likely keep you from passing away. I think that's a favor you owe yourself. And when I think about the health and wellness benefits of living, I embrace the COVID vaccine for me, and I'm going to be getting that, and I hope people do as well. And I just want to thank you so much for your commitment to this disease. I want to thank you too much to the commitment of the journey of the intellectual discovery that will follow with this, though. It's an exciting time to be in medicine for a lot of reasons, not the least of which is the mysteries get unfolded. Part of my message is I want the mysteries unfolded for every single New Yorker, so we can all have the health equity we all deserve, quite frankly, and have advantageous social determinants of health that we all deserve, and quite frankly, journey together to eliminate health disparities. So with that, I want to thank you so much. I hope you have a good rest of your conference. Have a good day. Bye-bye.
Great. Thank you, Commissioner. And I just want to thank you for your remarks regarding health inequity and health disparities, because as we all saw, COVID did have a substantively disproportionate impact on various communities around the country. The other thing I really liked was the notion of, as a Commissioner of Health, you're still reading Nature. And I think there's a nerd in all of us, because prior to you joining the conversation, Commissioner McDonald, Scott and I were talking about that same article. And lo and behold, we have one of the clinician researchers who was the co-author, Dr. Petrino, who comes from Mount Sinai. And Mount Sinai is indeed one of the leading organizations, academic organizations, that not just on the forefront of providing care because of its impact on healthcare delivery in New York City, but as a leading research organization. So we're very fortunate to have Dr. Petrino lead us off with regards to talking to us from the clinical and the more recent research perspective of long COVID as well. Dr. Petrino.
Thank you very much for having me, and yeah, it's a pleasure to be here and have the opportunity to discuss this. I wanted to, rather than have slides, I know we've got 7 minutes, so I wanted to just talk a little bit more informally about the things that we're seeing and the things that I think need to happen on a state level, if not a federal level, to assist us in caring for patients the way that we need to care for patients. And I would start off by saying, the theme here is going to be access. We hear a lot about people questioning diagnoses of long COVID, or creating barriers to people getting care for long COVID. But the reality is we have thousands and thousands of people in New York City who are trying to access care. We're completely overwhelmed. And what I want to talk about is, generally what would improve access. On a policy level, I think basic level access to care. I mean, I would say that Dr. McDonald was talking about all of the clinicians who got sick during COVID working frontline. We have a devastating lack of coverage for clinicians who now have long COVID after working frontline. We were happy banging pots and pans, during the pandemic. And now the line that most clinicians face when they're asking for benefits for their long COVID, is prove to us that you got sick on the job. That's the question they get asked, which is, first of all, absurd. Of course, no one can prove that, and should not be used as a way to withhold benefits from people who kept us safe during the pandemic. And I have many colleagues who this is currently happening to, at this moment. Of course, we also have lack of access to care for historically excluded groups in healthcare. We need to rapidly start to set up more and more long COVID clinics that access historically excluded groups in healthcare, and free clinics for individuals with long COVID. And we also have a significant lack of access for people with long COVID who have severe disabilities, who are homebound or bedbound. I have no options to send care out to patients. I recently got a grant from Uber that allows me to send clinicians out to patients in their home, but our level of care that we can provide there is minimal. So there's a lot of need on a systemic level, on a policy level, to allow us to actually give access to people that deserve it and need it. The next level of access I want to talk about is access to benefits. So, I'd ask everyone to consider the level of paperwork that we ask of patients to complete just to access disability benefits. It is outrageous. And I would say it's actually a failing of our commitment to uphold Section 504 of the Americans with Disabilities Act, because we're not making necessary accommodations for people who have exertional symptoms. A cardinal symptom of long COVID, as we know, as the NIH JAMA paper published, is post-exertional malaise. You are causing exertion on these patients by asking them to fill out endless forms, and we worsen symptoms. Many of my patients tell me that trying to fill out the forms just to get Social Security benefits has caused a flare, and so they leave them to the side and they don't get their benefits because it's so hard to access. So this is an accessibility issue. We're not making the necessary accommodations for folks with disabilities, and we need to do better on that front, because otherwise it's all on the clinicians, who also don't have time, and then patients don't get access. And this, similar to what we often hear with, we hear from, the Social Security Administration, not that many people are with long COVID are accessing benefits. It's because it makes, they can't get through the paperwork process. It's just like a lot of studies that claim that if someone is no longer accessing healthcare services, their long COVID is cured. That's not how it is. They're no longer accessing healthcare because they're too sick to access healthcare, and they figure, what's the point? The doctor's not helping me anyway. So we need to do better to make access to benefits more visible. And then, as the senior author on the recent Nature paper that came out, I would really stress that we need to believe patients when they present with subjective symptoms. Biomarker development is nice, and we're certainly on our way. But the CDC doesn't require it. You don't need a biomarker to be diagnosed with long COVID. So it's a mystery to me why people with long COVID are still being denied accommodations when their physician diagnoses them with a recognized disability under the ADA. And I would also remind everyone that what we showed in the Nature paper that was published on Monday was that subjective patient-reported outcomes had the same predictive value of determining who had long COVID and who did not have long COVID as the blood biomarkers. So what that tells us is, believe your patients. When they walk in and say, I have not felt the same since I had an acute COVID infection, that is enough for a clinician to say, I'm going to start considering long COVID. We're going to give you a diagnosis and we're going to move forward. That's access to benefits, access to treatments. We need to acknowledge the fact that most medications that we use in our clinic, things like H1 and H2 blockers for MCAS, things like immunotherapies for lymphocytopenia that we see, or immune exhaustion, T-cell exhaustion that we see, antivirals for Epstein-Barr reactivations, hormone therapies for hormone dysregulation that we see, all of these are off-label. Of course they're off-label because the science is still catching up. So clinicians are prescribing medicines that could help patients, but only if patients can pay out of pocket for these sometimes very, very expensive medications. We should be creating policy on a state level to make sure that if you have a diagnosis of long COVID, off-label medications can be covered by your insurance plan, because we're still learning, and this needs to happen. We also need, to that end, rapid approval of ICD-10 codes for clinical presentations such as post-exertional malaise. We need rapid approval of CPT and CAT3 codes for emerging interventions that seem to be helping patients, such as vagus nerve stimulation, hyperbaric oxygen therapy. This will make a lot of things a lot more affordable for patients and make them more functional, which is what the insurers are hoping for anyway. And then the final thing, I'll stop now, but the final thing that I'll just throw away is access to prevention. Again, if you want to trust me as the author of a paper on biomarkers, we couldn't identify anything that predisposed someone to getting long COVID, which means all of us are at risk, which means the only way to prevent long COVID is infection prevention. Don't get acute COVID in the first place. So can we please bring back masks in healthcare? Can we please put effort into, filtering the air? Clean air is a really good prevention strategy for long COVID, for acute COVID and infection prevention. Can we please use scientific strategies such as UV light to sanitize air as coming through the HVAC system? These are all things that will help us move toward a healthier future in general. So I'll stop there, but thank you for listening to me complain.
No, thank you very much, Dr. Petrino. And I just want to reiterate many of the things that you stated. First and foremost, I think, if I remember correctly, the Latin origin of the word doctor is to teach. And I think what you were talking about, whether it's your research, teaching the masses about what is indeed long COVID, and then the other thing that we as clinicians do is constantly advocating on behalf of our patients. And I think that struck out at me with regards to the comments that you made with regards to access to treatment, access to prevention. And then it started off with educating us that we have to listen to our patients. And just because the test doesn't say that you have long COVID, that doesn't mean you stop listening to the patients. I truly appreciate the remarks that you made, and within the context of being a teacher, a researcher, and an advocate for the patients that you treat. So thank you very much. We're going to move over to a bit of the macro side, right? So we had a clinician who's been advocating for, resources. And thinking about resources, one thing we've learned is we have to be able to kind of measure, how you define what the impact is at the macro level. And we're really honored to have Dr. Cutler speak to us from that vantage point. I've been a fan of his writings on health economics, and I'm really glad that he's here to educate us from his perspective. Dr. Cutler.
So thank you so much. And let me echo my praise for what you've been doing at the fund there, because it's just been enormously important work telling us about the extent of long COVID and what people are doing and how much it's costing. I mean, it's just as you've been noting, it's a huge problem, and it's just great to see it. So I thought what I would do is tell you about some of the economics of long COVID, and give you a sense of where, as best we can tell, where it's bigger and smaller, and a bit about what we know about the costs and things like that. So let me just then tell you a little bit about it. So first, let me start off a little bit with what we know about the prevalence of long COVID. So the best data we have for the country comes from a thing called the Household Pulse Survey, which started off during COVID, and so it sort of asks people how they're doing and stuff like that. And so you can see here the prevalence is variable by age. Overall in the population, it's about 5.5% of adults, which translates into about 14 million American adults. That's kind of quite a lot of people. And you can see here that long COVID is unfortunately particularly important in working ages. Unfortunately, because these are sort of people who need to earn money and whose livelihoods depend on their ability to be able to work. And you see here that in the sort of prime working ages is when long COVID tends to be highest. I fear it's somewhat lower at older ages because of mortality of people with COVID, whereas people in middle ages tend to survive more, but then develop long COVID. Interestingly, it's fairly uniform. We're actually rising a little bit with the number of years of schooling one has. So one thing you might have worried about is, well, okay, is long COVID particularly affecting people who have, say, a high school degree or less? We're not seeing that here, although I am mindful of Dr. Petrino's admonition. This is self-reported long COVID, and whether you say you have long COVID is a little bit different from whether you actually have it, and it can manifest itself in many different ways. So you need to take everything here with a little bit of a grain of salt, but just to give you a sense, it's what you want to think of here is sort of a person with a job that's a sort of service industry face-to-face kind of job, and that's your kind of typical person with long COVID here, and that's particularly consequential because many of those jobs are difficult to kind of substitute other things for doing that, and so that sort of makes it be somewhat hard. Although I want to come back to that a little bit at the end. In terms of the industry composition of people with long COVID, I couldn't find this nationally, but this is for Washington State. The biggest industry, unfortunately, where people that the industry that people came from, because not everyone with long COVID is working, is actually healthcare and social assistance. So these are doctors, nurses, orderlies, people involved in the healthcare space who had COVID and then that turned into long COVID. So that's the sort of disproportionately high end here. On the somewhat lower end are, for example, educational services, somewhat less likely to have long COVID than the share of employment. So the orange is what share of the population is employed in that industry, and the blue lines is what share of that population has long COVID. So sort of equal heights mean it's equally spread throughout that industry. So you could sort of see healthcare is big, and this is a big deal for a lot of circumstances. For example, many hospitals spend a lot of money on temporary nurses, out-of-state nurses, other kind of non-full-time employment because they can't get the workers. And at least part of why they can't get the workers is because the workers are out with long COVID. That's not the only reason, but that's part of the reason why that issue shows up. There's a range of symptoms, and Dr. Petrino was talking about this. There's a range of symptoms relative to the 5.5% of the population that's currently experiencing long COVID. About 80% of that, so 4.5% of the population, has some limitation. So if you say, are you limited in any way by long COVID? About 14 million Americans will tell you that they are. And then if you have significant limitations, that's about maybe a fifth of those with long COVID. So it's roughly about 3 million people who say they have significant activity limitations because of long COVID. Somewhat interestingly, over time, the share of people who say they have long COVID has been declining. So people are recovering. It's early on, in my mind, I was looking at SARS and MERS for data for how long people would experience symptoms of long COVID. And the guess from those conditions was that the typical person with long COVID would have long COVID for about 5 years. I think we don't have, the data aren't great enough to do this well. I think that it's coming in a little bit less for long COVID than it was for example, long SARS. So that is, people are recovering a little bit faster. That would be very good news if people are recovering faster than they did from other conditions. That's not, but I really want to see a lot more, because it's sort of confounded because the surveys don't ask when did your condition start and do you have them now? So it's sort of trying to draw various guesses about that. But still, roughly about 3 million people with very significant limitations, another 10 million or so with some limitations. What are the economic costs? Well, to a family, there are a lot of economic costs. There's decline in income, and I'll show you a bit about the employment situation in just one slide, which is sort of very big. But you sort of see up to between a third and a half reduction in individual income. About a quarter of long COVID patients in the U.S. say they've had employment or work hours affected. Financial stability increases, homelessness increases, moving locations, residential locations frequently increases. At the same time that people experience an increase in medical costs. So chronic fatigue syndrome is a rough parallel. That's about $9,000 a year of additional spending. Even then, of course, you find people who can't afford it, or who don't think that the care is doing well for them, don't have insurance, things like that. So there are a bunch of costs to families. Economically, I've tried to estimate 3 kinds of costs. One is the health costs of long COVID. That is the reduction in just the value of being alive and good health that we get because we're alive but not in as good health. Second is the earnings loss. There are fewer people at work and people working earn less. So the combination of those two is an earning loss. And then third is health spending, which is more money that we're going to spend treating people. That's a loss in the sense that those are resources that we can't use for other things. Those are doctor time, nurses time, other assistants time, that pills and hospital stays and so on, that are not able to be used for other things that we want to have. Other things are very important, DI, receive workers' compensation, so on. Those are in economic terms transfers. That is, they don't lower GDP, they don't lower the amount of stuff in the economy, but they change who we give it to. So we give it, hopefully more of it to people with disabilities than they would otherwise receive and so on. So those are very important, but they're not kind of aggregate, if you will, economic losses. My estimates, I think these were sort of early on. I haven't, because we don't have great data, I haven't been able to totally update it, but I think these are roughly about right, is that long COVID, the cost of long COVID for all the people who you would guess would have it is roughly about $3.5 trillion, or about $11,000 per person in the economy, roughly 17% of 1 year's GDP. And that's obviously a very big number. That's just a huge loss to the economy from long COVID. And that's, you can see a lot of that is just people are less healthy, and that's worth something to people. People like being healthier. But then there's roughly $1 trillion of reduced earnings. There's roughly $500 billion of increased medical spending. So this is just a lot of loss from long COVID. You can see some of the earnings loss here. So this is people who had COVID-19. These are workers who had COVID-19. The time zero here is when they start having a health-related absence, where COVID is the health event. So that's sort of the impact of COVID on the health-related absence. And then what you then see is, so obviously employment goes down because they have a health-related absence. And then what you're hoping for is that it would come back. That is, people at some point would return to their jobs. In fact, people are returning, but not fully. And so the fact that these lines on the right are below where people started off is that people are not fully returning to their job after they miss after they miss some time at work with COVID. And so that's kind of where you're seeing some of the employment losses here. It just don't look like, even when you look over a year later, people have not fully returned to work. It may not all be long COVID. Some may have just decided to retire or to do something else, but a part of that is going to be long COVID as well. There are up to 2 million people likely affected in some way, for example, reduced hours from long COVID. So let me just give a couple of implications. In fact, I think I'll just do this one and then I'll stop. What does this mean for employers? One of the things is that employers are really going to have to deal with accommodations for long COVID patients. Obviously, telework is a big deal there. But even more than that, even when not during telework, flexibility in terms of working hours and deadlines, frequent breaks. I know one individual I was talking to with long COVID, had to go up and down flights of stairs all day, and that was very difficult. And so they switched a job with the employer where they didn't have to go up and down stairs. And that worked out fine for the employer. Like, it wasn't a huge accommodation, but it was something that really mattered a lot for that worker. Brain fog related prompts. So these are things like, how can you help people who are experiencing brain fog? One of the things that may be particularly helpful is the last thing here on the list, which is potentially, can we use AI, in ChatGPT to help people pre-fill in things so that they're not using their brain as much, that some of the time their brain can be relaxing while they're doing other sorts of things. Sitting breaks, frequent sitting breaks, and so on. So when you think about accommodations here, you don't have to think about, building a new ramp and building, and fully changing the nature of what the firm does, but you can think about lots of things along the way that can help people out. And I think those are going to be particularly important as we continue on with long COVID, and we have to get used to an economy that has a lot of people like that. So let me stop there and just thank you so much, both for all the work you've done and for inviting me to be with you.
Thank you very much, Dr. Kotler, for that really macro level perspective on the impact of long COVID. And I think we're really fortunate that we're going to now move to the micro level, because I think it's just as important to complement what we know, the impact of long COVID at the macro level, but then be able to appreciate what happens at the local level, at the individual patient level, and then also be able to advocate from that vantage point. So we're really very, very fortunate and lucky to have Ms. Nisha McCrae, who's been advocating on the behalf of individuals who have long COVID, bringing awareness, making sure that the resources that not just Dr. Petrina talked about, but from the vantage point of what even Dr. Cutler mentioned, she's been bringing that perspective from the micro level. And we're really fortunate to have her speak to us with regards to her own experience and the activities that she's involved in and what she's learned. Ms. McCrae.
Thank you so much, and thank you all for having me. I would like to start off with, in my community, I'm from the rural South, in particular, Northern Florida, and I was always raised that it's not if you get a disability, it's when you get a disability. And that quote always stood with me as a child because I was raised that a disability wasn't simply physical or tied to old age or an unfortunate accident. A disability can be a natural disaster, has made you homeless. You are now disabled from pursuing additional work, or the fact that there's an economic crisis and you're now disabled from pursuing additional economic opportunities. So from my perspective, I've always been raised that prepare for when you are disabled, whether temporarily or permanently. So taking us all the way back to that wonderful time in February, March of 2020, I was in New York City wrapping up some stuff for my nonprofit Bajika in order to expand our STEM educational offerings for students not only in the United States, but around the world. And at that time, I had colleagues who were in Italy as well as Wuhan, who were giving me updates about the situation. And given that quote I've been raised with, I was filling up my sandbags for my organization as an employer. Because as a leader, I know that at the end of the day, my employees, staff, volunteers, and the families we serve look to us, especially because we are a leader in science communication, which means we take the chaos of very advanced and technical terms and make it accessible to the people we serve. So I was already in filling up those sandbags, and yet even I was not prepared for the next 3 years, what they would entail. As an employer, I've always had to battle as a female employer and as a woman of color who employs a bunch of people that sometimes you can employ a policy that may not be a policy that your colleagues in the field may utilize, and you may be seen as weak or too feminine or too empathetic. And a lot of times I like to say that even in the nonprofit space, sometimes our policies are looked at as, oh, they could be ripe for abuse. Oh, you're being too lenient. How are you being hyperproductive? And what I can say from the past 3 years of our experience is that there needs to be a mindset shift in what is the only way we can operate as an employers in order to make sure not only do we do what's right for our employees, but also that we do what's right for our business. And I think there's a balance that can be struck from that. And I'll give a couple anecdotes from my experience the last 3 years on the micro level that will kind of echo what you will hear today. In March of 2020, when I say I was filling up sandbags, I was already gathering toilet paper, ordering online extra rolls. I was already ordering masks, I was already ordering hand sanitizer before we went into official lockdown. And I was making care packages for families who already knew were in financial situations that could not handle such a blow, as well as my staff. One of my employees, I'll never forget this, was like, Miss Nisha, you're so paranoid. Like, when are we ever not going to have toilet paper? I don't know what you're doing. You need to stop hanging out on the internet. And for me, I was like, well, worst case, we can use it a little bit later. But for me, I know you won't be able to do your job if this isn't covered. So it's worth the extra couple of bucks for me to make sure you're okay. Fast forward 2 weeks later, we're on Zoom trying to figure out how that works and trying to figure out who needs a hotspot because they thought their Wi-Fi was stable and it's not, who needs a Staples delivery for a webcam, headphones, everything. And the number one request, despite all of that happening, was toilet paper. And at that moment, I thought, I got this down. I'm like the best boss ever. I already saw, and I just skipped over that little pothole, fantastic. And then I started to notice I was getting messages from my employees. And I was going, why are they saying they're not feeling well? Now, mind you, our community is very densely populated. So we understood that if there was going to be any outbreak, it was eventually going to hit us. But we did not expect only 7 days before we would become the new faces of the COVID pandemic. And slowly I was getting messages of, hey, have you heard anything about like not being able to breathe? Like there's an elephant on your chest. Hey, my eyes are bloodshot. Hey, I cannot go up a flight of stairs. And as an employer who was actively transitioning from physical workshops to virtual workshops at the time and managing the logistics of that, the last thing I needed within the same week was having half of my team immediately out of commission because of a mysterious illness. I was trying to coordinate COVID tests. I was trying to coordinate grocery deliveries to support my staff during this time. However, what I didn't realize was that I was going to be the next victim of that. And a couple of days later, I started to realize that I didn't have the energy I had a couple of days ago. And then one morning, I got up early in the morning because I just felt ill. And I was trying to go to the bathroom to refresh my face. And that was the last memory I had before I passed out on the floor. I couldn't breathe for about 6 months after that moment. And the entire time, me and my team are scrambling on how are we supposed to educate hundreds of kids who we're the only semblance of normalcy to for that period of time. Some of my employees were unable to sit up. Some of them were texting me saying they feel like they're going to die. Could I please help them get a living will so that way they can make sure their family's taken care of? I don't wish the experience as an employer, especially one whose team has allowed for them to see their greatest dreams come true to make the world a better place, go through what I went through in 2020, let alone what I went through personally as a long COVID patient. However, as we progressed through the pandemic, we started to notice a lot of the hiccups I thought I was filling up those sandbags for were still causing us major issues. And I was having colleagues who didn't know I had long COVID as well, who were hearing through the grapevine that we had to cancel a workshop or we weren't able to fulfill a certain business contract or obligation and had to pull out because of our employees going, oh, you're too empathetic. I would have fired them. You're wasting too much money. Why don't you just boot them off your health insurance plan? That will save you a ton. Why are you letting this person call in sick? You know they're just using long COVID because it's the latest thing to get out of work. Have you heard of quiet quitting? And all of these comments were coming to me in my inbox. And none of these individuals, my own colleagues for over a decade, knew that I was bedbound and unable to feed myself, clothe myself, or do anything that would be considered independent. And my team was scraping together all the energy they had, suffering from long COVID as well, to keep the lights on in our building. So I finally, after a couple of months of being able to finally be able to speak and sit upright after a year and a half of not being able to do either, started having conversations with my colleagues and went, do you see a number of your employees coming in, not remembering tasks, feeling like they need to take frequent breaks? And in our region of the country, we have a lot of stairs, as was mentioned. Do you notice that your employees try to avoid the stairs at all costs? And they will go, yeah, but that's just because they're used to working from home. They're just being lazy. And I would have to pull them aside and go, I am your employee and I am suffering from long COVID. And if I could give up every item I have in this world, I would, for the ability to breathe properly and have the energy I once did. My background is engineering. There is no way I can explain to you the devastation when you wake up and you have a client send you paperwork for a product you're manufacturing for students, and you don't even know 2 + 2. You can't even figure out how to do 2 + 2 on a calculator because you have forgotten the entire pathway in order to process that. How am I able to show up and do my work? How am I able to lead? And if I'm not able to do that, how are my employees able to do so? What my experience with long COVID led me to doing was, instead of being afraid of how people would perceive me as an employer, adapting to what my employees needed. I basically said, I don't care. Because if my employees need X, Y, and Z, it is in my benefit to do so. So 2 years ago, as I noticed I was going from severe long COVID to moderate, I had an emergency meeting with my team. And we figured out what were the top 3 asks that we needed in terms of accommodations that everyone could agree on. The first one was prevention. Every time we had a staff member who was well enough or who had avoided long COVID, they were immediately getting a COVID infection when they were interfering with the public or interacting with the public. So we decided, even though the vaccines were at this point available, we will continue doing COVID precautions and recommending COVID precautions for anyone interacting with our staff. The second one was flexible work options. Long COVID is a dynamic disability. And what we mean by that is, today I'm able to talk to you, sip a coffee, and keep my energy up in order to remember the notes on my phone. Yesterday, I wasn't even able to carry on a conversation for longer than 10 minutes. And that does not allow for the stability needed in the previous model of work. But if we allow people and trust employees that they know what's best and how they work and what they need, whether it's working remotely when needed, not requiring in-person hours as much as possible, and allowing for people to take PTO or a medical leave as much as possible, that was the second ask. And the third and final ask was empathy. As their leader, most of the time, my employees looked up to me, but at that moment, I didn't understand what that meant. If I was pushing through my post-exertional malaise, they felt they had to push through the post-exertional malaise. And when they would go through a relapse that would last days and weeks, I was the cause of that because I refused to humble myself in that moment and lead by example. Now I make sure my calendar is public. And when I say I'm having a relapse in symptoms, we are canceling this workshop. If you have any problems for the client, you direct them to me. You do not handle that issue. The morale of my team has switched night and day. And so what I would like to share with other employers is that it's scary. It's scary having to pivot, and what was the old model of doing business, having to shift to something new, especially something that you've been told and trained was you giving up the right or your power. But I will end with this note. In the past year and a half since we shifted to this new model, we've gone from the organization no one calls, because no one wanted to be reminded of masks. We were requiring vaccines for those who wanted to volunteer with us. We were requiring that individuals at least consider wearing a mask. We will cancel if we felt there was a COVID infection amongst our staff. And we felt we were the weak ones in our field because we were still holding our foot down because we understood the cost of not doing those things. Fast forward to just yesterday. Due to the recent COVID outbreak that is happening in several public school systems at this time, we are one of 2 out of 112 nonprofit organizations providing STEM education in the New York, Boston, New England region who still has full staff available to do any type of outreach at this point. And we have dozens of emails asking for our services. What went from something I thought was showing I was a weak leader and wasn't fit to be an executive director has now become our strength, because now we can consistently predict, I know I will have at least 1 or 2 staff members. Infiltrating, as we heard Dr. Petrino say, filters, masks, making sure that you provide flexible work schedules. Instead of this stop and go I've noticed my colleagues discuss, we've been able to consistently put out work and make an impact. So that's what I will leave you all with today of what it looks on the micro level. Believe your employees, make accommodations, and I know it may look like the costs are high in the short term, but I promise you, whether it's the long-term cost of retraining someone, replacing that individual and their institutional knowledge, or just the fact that you're increasing morale, the long-term cost of not changing your model right now is tremendous, and in some cases insurmountable.
Thank you very much. That was really well stated. And thank you very much for sharing your personal and professional experience and educating us on how to address and deal with the continued impact of long COVID. So it's a really very, very helpful. So we're now going to turn to Dr. Bu, who's going to provide us from her vantage point the impact of long COVID on the workforce, specifically addressing the challenges when it comes to gender and healthcare disparities. And what is it that we can better do to understand these challenges and respond to them?
I'd like to first start off and just talking about how the pandemic really has highlighted racial and gender disparities that already existed in the workforce. So example, unemployment. Historically, Black people are twice as likely to be unemployed as their white counterparts. That's even across educational attainment. In 2020, April 2020, when the pandemic started, unemployment was high across the board, 14.7%. Black unemployment was very high at 17%. White unemployment was very high as well at 14%. Later on, by October of that year, the white unemployment rate fell down to 7.9%, and the Black rate was still almost twice that. Things have improved. The latest numbers in September showed that unemployment rates have, of course, improved, but we still see high unemployment rates for the Black population of 5.3%, 4% for Latinx population, and 3.4% for white population in the U.S. There's also the issue of occupational segregation. So I do research on something that's called occupational crowding, which looks at how people are under, over, or proportionally represented in different occupations, taking into account their human capital, their educational attainment, and what the educational requirement is for that work. What's been found in the past is that Black men are overrepresented in low-wage work and underrepresented in high-wage work, again, taking education into account. So you could have, for example, a Black man who's a college graduate, and because of labor market discrimination, finds himself in a form of work that doesn't require as much education and pays a lot less. My research applies this to Black women and found the same was the case. Black women are overrepresented in low-wage work, as well as work with fewer benefits, and underrepresented in higher-wage work with more benefits, again, even taking education into account. So an example would be a home health aide, which is an occupation that pays less than $25,000 a year. Less than half of home health aides have employer-sponsored health insurance, and just a quarter have retirement coverage from an employer. We also know that this is a role that is care work that has high proximity to other people. And this is the role where Black women, as compared to white men, are overcrowded into this role. Their expected share in the role would be 17%, but instead it's 87%. So they're very much overrepresented. In the wake of COVID-19, when that started, I was working with Derek Hamilton and other colleagues at the New School. We started looking at occupational crowding in essential work. We know that looking at it was important because these roles would have more disease exposure as people were expected to continue to work in person. I can imagine these roles could mean that people have higher risk of long COVID in particular. We found that white men are crowded out of essential work, again, even after taking education into account. And in comparison, Black women, Latinx women, and Latinx men were crowded into essential work. We also looked at how immigration status impacts that, and looking at the food and agriculture sector, which is one that is very much low paid, very hazardous. We found that Latinx men who are not citizens are 250% more likely to be in the food and agricultural sector. And they also earn only 71% of average wages. That was something that was particularly something that we wanted to look at, given that sector was particularly dangerous and also very important as people were trying to access food in the wake of the pandemic. And then lastly, I'll mention there's also the issue of, and I started to allude to that, uneven wages. We know that there are big wage disparities for workers of color. There's gender wage gaps. Some of that does have to do with occupational segregation. So when you are concentrated to lower paying roles, you're going to see that wage disparity. But something that also comes up is even in the same roles, there are wage disparities. So for example, when employed as a chief executive, Black women earn 67% of average wages. White women earn 79%, white men earn 112% of average wages. And I mentioned our essential work that we did, looking at occupational crowding there. What we found as well is that when they are employed as essential workers, Latinx women earn only 54 cents on the dollar. Black women earned 61 cents, Latinx men earned 68 cents, and Black men earned 69 cents, and finally, white women earned 83 cents. In contrast, white men earn 30% above average wages. So all of this is something that was happening before the pandemic and continued in the pandemic. It certainly has implications when we think about the type of work that people are doing that also puts them at high risk of disease exposure, including the possibility of long COVID. Many of my fellow panelists here have talked about how long COVID impacts worker well-being. There's a study by some of my colleagues at the Urban Institute. It was called Employment Material Hardship Among Adults with Long COVID in December 2022. It was written by Michael Cartman and other researchers. And so they used data from the Urban Institute Wellbeing and Basic Needs Survey, which is nationally representative. And I'll share a few of the things that they found, which are certainly reflect some of the findings in the Household Pulse Survey. So they found that 1 in 10 adults with long COVID reported they stopped working for a period because of their symptoms. They also found that adults with long COVID were less likely to be working than adults who had COVID-19 but didn't report current long COVID. They're also more likely to be out of the labor force for health or disability reasons. And that, of course, is going to impact your ability to pay your bills. In fact, they found over 4 in 10 adults with long COVID reported food insecurity, with 1 in 4 reporting very low food security. And they also found that 1 in 5 adults with long COVID had trouble paying their rent or mortgage, and nearly 1 in 4 had trouble paying their utility bills. But they also found challenges for people who were able to continue to work while having long COVID. They found that people with long COVID are less likely to have benefits. Only 59% of adults with long COVID worked for an employer that had gave them access to sick leave at their jobs, compared to 68% of all workers. They also found that 1 in 4 adults with long COVID said they spent less time doing things outside of work, so socializing, doing errands, in order to continue working. So you can imagine that really impacts their well-being. There are also equity implications of this. It's notable that in that census Household Pulse survey, based on data from June to December 2022, Black and Latinx respondents were more likely to report long COVID symptoms. Black and Latinx workers already face disparities in income, benefits, and wealth, and the addition of this of long COVID already compounds these effects. So just to close off, I'll talk about some implications for both policy and employers. For policy, I think the findings that my colleagues at the Urban Institute were able to demonstrate show that the importance of policy that ensures that there's paid leave so that people who are suffering from long COVID are able to pay their bills and can recover and avoid having to go to work and possibly getting worse or even spreading COVID to others. The findings also point to the need to ensure that people can manage their basic needs, which suggests the need for a larger safety net. So things like more supplemental nutritional assistance or SNAP, Social Security Disability Insurance or SSI, health insurance, and so on. And also thinking about increasing asset limits on asset building and safety net programs so that people who have disabilities such as long COVID are still able to receive Social Security benefits while working. And I'll also point out that many, over 100 cities have been experimenting with guaranteed income programs, which would provide direct cash assistance to people, which would certainly be helpful to those who are not able to work due to long COVID. And for employers, so Nisha McCrae beautifully mentioned the importance of prevention and many different ways that she's accommodating her employees, and Dr. Petrino also talked about other prevention methods as well. So I won't repeat some of those, but what I do want to point out is the equity implications that come to mind to me for these as employers are thinking about ensuring that there are reasonable accommodations, just making sure that that's offered to everyone and given to everyone, regardless of race, ethnicity, gender, and any other identities. I also want to point out that we know that people in higher paying roles are more likely to have remote work as even a possibility. And even prior to COVID-19, Black workers were less likely to work remotely. Part of that has to do with that overrepresentation in certain sectors, like care work that doesn't really lend itself to remote work. So we have to think about ensuring equitable access to all types of roles. We also have to think about how employers respond to concerns that workers raise about safety. Back in 2020, the National Employment Law Project found that Black workers were more likely to work in conditions that were considered hazardous or repressive, and also face retaliation when they raised concerns about safety. So ensuring that when concerns about safety, whether it's long COVID or any other safety issues brought up, that they're treated respectfully and actually addressed so that workers are safe. So to sum up, there are a number of things that policymakers and employers can do to address long COVID, ensure that issues of equity are also addressed in that in the course of that work. Thank you.
Great, thank you very much. Our next speaker is Dr. Vaughn Schroeder. She is going to speak to us from the vantage point of what is it that the employer needs to think about, what are the resources that they need to have in place, what are the challenges that the employees who have long COVID will be coming to them with, that they need to be prepared for to have a smooth transition in their workplaces.
So thank you for the introduction, and thank you very much for having me here today. I've learned a lot from the various panelists who are here today. I really appreciate sort of the variety of viewpoints, and I'm going to say that a lot of what I'm going to be presenting today will be similar and along those same lines. So thank you for putting that out there. I am, in my role, I am part of the Northeast ADA Center. I just wanted to put this out here because I think it's a great resource for employers and for individuals. We support New York, New Jersey, Puerto Rico, and the Virgin Islands, but this is there are 10 national ADA, 10 ADA centers across the country. We provide training, technical assistance, consultation, and materials on a broad range of topics related to disability in the United States at no cost. So this is 1-800 number. So if you have questions about disability or long COVID and how it might affect employment or any other aspects of the ADA, I encourage folks to call. It's a great resource. We're supported by the National Institute on Disability, Independent Living, and Rehabilitation Research. I'm going to also start off with some statistics, and I think these are things that we've seen a few times before, mostly based on the Census Bureau's Household Pulse Survey, and we looked at some of the most recent data that we have, which is the July to August range. About 15% of all adults age 18 and older have experienced symptoms of long COVID. When we sort of narrow this down to the working age, Dr. Cutler, I believe, already sort of talked about how the prevalence seems to be higher within the working age population. So about 12 million working age persons are currently experiencing long COVID symptoms. And another note that slightly over 3 million working age persons are currently experiencing significant activity limitations due to long COVID. So that's quite a big number of people who are being impacted, and as we've talked about before, there are certain groups who are potentially more likely to experience significant activity limitations. Women are more likely than men to experience significant activity limitations. People with disabilities with long COVID are over 7 times more likely to experience significant activity limitations. And there's also variation by race and ethnicity. So as we think about this, I think this is really important information for employers to understand sort of the scope of this issue. So I'm repeating this number again. I think we sort of talked at the beginning with the commissioner talking about health disparities. And I think it's important to note that the NIH just, I believe this week, designated people with disabilities as a population with health disparities. So with that, there's designation, there's a new research program and an update to the National Institute on Health mission to improve the inclusion of people with disabilities, which is very exciting. So what employers should know about long COVID? There's nothing new here, but I'll just continue to say that I think this is all very important, that long COVID is not just one illness. While we may have a test soon for long COVID, it's not just one thing. It's not a simple condition. And it's important for employers to understand how the different ways long COVID can present so that they can better think about how they can support their employees and their needs. So the symptoms experienced by those with long COVID are varied. I think that's important. There's the variety of symptoms can be mild, others can be debilitating. These symptoms may change over time. They could go away, they can come back, they can last weeks or months or years. These symptoms, as we've talked about, include fatigue, post-exertion malaise, brain fog, shortness of breath, headache, chest pain, cough, and depression and anxiety. And as the EEOC has written about, long COVID can be a disability under the ADA. So in terms of accommodating long COVID, this is one statistic I kind of like to bring up whenever we're talking about any kind of accommodation, disability-related accommodation, is that when we're talking to employers, in some work we did with the current population survey, 95% of accommodation requests are from people without disabilities. Employers are supporting their employees all the time in different ways to meet their needs in the workplace. And so I think we need to think proactively about how we can support employees, our employees and all of our employees. A big part of that is creating a flexible and supportive workplace. Accommodation and flexibility should be offered to employees with long COVID early. So ideally, we're not waiting until they need a diagnosis or documentation of that diagnosis so that they can manage their conditions and if they choose to stay at work. That is really important. Long COVID can be unpredictable. So again, sort of when available, workplace flexibility and remote work options or various accommodations are an important way for employers to manage their conditions. And we need to make sure that employers are aware of that and build that into their systems, if at all possible, that flexibility. We also want to build awareness of long COVID and the accommodation process among employees, supervisors, and employers. Ideally, we can have training and resources for supervisors and and their coworkers so that we can build awareness in the workplace about long COVID and build empathy toward workers with long COVID. Also, we want to ensure that employees and supervisors are really aware of the accommodation process. Ideally, that process is really transparent so everybody knows what the accommodation process is, the steps, the timelines, and the roles and responsibilities. The process of requesting an accommodation can be stressful for an individual. And so knowing what's going to happen is very important. And that disclosure as well can be very stressful. So making sure that everybody understands that process is key. With accommodations, no matter what disability we may be accommodating under the ADA, one size does not fit all. Particularly with long COVID, there's a really varied set of symptoms and presentation of long COVID, and there's no accommodation that'll work for everyone. So it's best to, flexibility may be really important to some, and for others, there may be other things that can support them. So always it's best to engage in a dialogue with the employee so that you can really understand their needs and consider the resources that may be available. And there are lots of resources, which I'll talk about more, but one great one is the Job Accommodation Network, which has lots of resources and also has a 1-800 number that you can call and get information about how to support employees given different things. And one resource that I liked that I think can be helpful for employers as they're thinking about how they might provide accommodations are some questions to consider. And I think this is helpful for employers, but it can also be helpful for employees who are thinking about going in and talking to their employer or requesting an accommodation. So I'll just go quickly through these questions. It's important to think about what the limitations are that the employee is experiencing. How do those limitations affect the employee and their ability to do their job? Are there specific job tasks that are problematic? As a result of these limitations, we talked about going up and down stairs. Is that something that is more of a marginal function of their job, or is that something that's really necessary? And so then having a dialogue about what accommodations may be available to reduce or eliminate these problems. There's all sorts of resources to help identify possible resources, and having that dialogue is really, really important. Finally, once accommodations are in place, it's really useful to follow along with the employee to evaluate whether this is really working. and whether there are additional accommodations needed. And as we talked about, the way long COVID presents, conditions and how people are feeling can change, hour to hour, day to day, month to month. And so I think really emphasizing for employers to check in and see how their employees are doing. And then finally, do supervisory personnel and employees need training? We talked about that a little before, both on the accommodation process, but also understanding more about long COVID. This is an example. So tiredness and fatigue is a common symptom of long COVID. So the Job Accommodation Network offers, for a number of different limitations, an array of accommodations. And I think this just shows sort of the range of accommodations that may meet the needs for different types of limitations. So allowing rest breaks, providing an ergonomic workstation, allowing a flexible schedule, restructuring the job to remove marginal functions, and allowing telework. And so a lot of these are not, some of these will not be available in every kind of job by any stretch, but they are options that may work for the employer and the employee and might give some ideas. And so they have a whole list of very accommodations ideas that are in many cases no cost options. So I am going to leave with a few resources for employers that I think will be very useful. From the Employer Assistance and Resource Network and the Job Accommodation Network, there's resources on supporting employees with long COVID. There's technical assistance guidance from the Equal Employment Opportunity Commission. And finally, a mental health toolkit from the Employer Assistance and Resource Network that can offer some great resources as well. So with that, I would like to say thank you very much.
Great. Thank you very much, Dr. Schrader. And thank you to all the panelists for your remarks. I'm going to just pose a question to each of you. And I'm going to start off first with Gaurav. The vantage point that you have, being at the leadership role at one of the largest workers' comp fund and doing this unique study with regards to its impact, I'm wondering, what are some of the other organizations, what are the other workers' comp organizations, what are they doing? And how are you connected with them, whether regionally or nationally, to pool this type of an effort to better respond to the needs of the workers and the larger community?
I think it's actually heartening to see that there is interest within other organizations at the state level and various organizations that bring the states together. And we're seeing interest, and we're seeing growing interest, and we see it firsthand in our participation on a state level CDC working group that we're part of. Those conversations are very enriching. People come prepared, they make presentations, lots of wonderful information is exchanged in that venue. There have been other reports that have come out. Many of those reports take different approaches, establish different thresholds in terms of analyzing the information. For our report, what we looked at was the symptoms backed by corroborating information within employment records and medical records. I think the good news is that as we look at what everybody else is focused on at the state level within different organizations, there's a realization that long COVID is real, fundamentally, and there seems to be a very genuine and growing interest in working together to solve a lot of the informational gaps that exist today around long COVID, as we've heard from this conversation. So to be a part of that dynamic is very rewarding, but I think will pay dividends in the medium term and long term as we try to understand, this condition a little bit better.
Great, thank you. My next question goes to Dr. Cutler. In your presentation, you talked about the substantive impact, 17% to the GDP, quite, huge. And there's a term, and I'm sure you know this better than I do, in terms of the investment that is made at the public level, right? I think they call it the marginal value of public funding. And I'm just wondering if you can shed some light on, as we as clinicians typically think about prevention, and is there any data out there now that shows the marginal value of that public investment into preventing COVID or into addressing some of the needs of long-term COVID patients that can potentially mitigate that long-term economic impact that you so wonderfully illustrated?
Yeah, so thank you for the question. It's the dollars are so big, $3.5 trillion. And earlier I had worked on trying to estimate the cost of COVID, which along with my colleague Larry Summers, we'd estimated it to be $16 trillion. So even obviously bigger. Those numbers are so big that there's no amount of public investment in trying to help people or search for cures, or there's no amount that's overdoing it. Like if you could say, so let's say you have something that you think is a $3.5 trillion problem. Suppose someone comes to you and says, well, should I spend $50 billion to try to fix it? Right? $50 billion. Well, that's nothing in compared to the scale of the problem. So the only criteria that makes any sense is, does the investment have any chance of working? And if it does, then we should be doing it as much as we can. And if it doesn't, okay, don't waste your money there. But it's like, sometimes you're sort of saying, well, the returns are modest, and so, therefore I have to be careful with my dollars. The returns here are so vast. The benefits of doing well here are so vast that there's basically nothing that would discourage you from spending much, much more on how do I treat people? What kinds of accommodations can work for people? What do I need to do with respect to the disability system and the medical care system and the role of families and all of that, the role of medical care, like all of those things. There's just nothing that we shouldn't be doing.
Okay, good. My next question goes to Dr. Petrino. As a practicing clinician, right, working in a healthcare organization, as we saw from the data that healthcare workers are indeed at the forefront of getting COVID and then long COVID. I'm just wondering, what kind of challenges have you encountered when it comes to the medical record, and even Gaurav alluded to, and workers' comp, right? And the two don't meet on many occasions, in most occasions, for a variety of, I don't know why, but they just don't. And I'm wondering if that's something that you've encountered, and if there's something that we can do on the workers' comp side to mitigate that challenge, that administrative challenge for the individual patient, going to my diabetic doctor over here and going to my workers' comp COVID long-term doctor here. I'm just wondering if you have any insights that you could share that Gaurav and team could potentially think about piloting efforts around that.
I think the first thing that by no means would this completely fix the problem, and this is a complicated problem, but I think the first thing that would go a long way would be to have a little grace for people who were designated as essential workers during 2020, to be told, actually, it doesn't matter. You don't need to prove to us that you got COVID on the job. I think that has been the single biggest barrier to essential workers during 2020 getting access to workers' compensation benefits. It keeps coming back to, how do we know that you actually got sick while you were working the job? There's literally no way of proving that. That's an impossible thing to prove. And it's an impossible situation to place someone who's desperately ill into. So if there's one thing that I could do, I would say, you know what, if you're an essential worker during this period in New York City or New York State, obviously, we're not going to ask you to prove that you got it on the job. We're just going to say you were working an essential job and you got sick, and now you continue to be sick.
But that's an excellent point. I really appreciate that. And just kind of following up to Ms. McCrae as an advocate, right, in terms of not just as an employer, as an employee, how would you want to communicate, some of those challenges and concerns that your staff have to a group like the Workers' Comp Insurance Organization, right? If you had the opportunity, and you do now, to speak directly to Gaurav and say, hey, Gaurav, I have these 50 patients and, I want them to be able to come to you because, much like Dr. Petrino said, they were working for me during that time period, and I don't want them to prove that they got COVID while at work. Just support them. There's Gaurav for you. Do you want a pilot project?
Well, thank you. And I have a little bit of experience on this because the past 2 years I've been fighting for a bunch of my staff members as well as myself trying to navigate this as well. I would say there seems to be a huge issue that everyone's touched upon, is that everyone is used to operating in their silos. And the models and systems that we have in place in 2019, I like to refer to it as it is what it is. Like, we can't change that. We have strict ways of showcasing. You have to prove you got it on the job. You have to prove you have this diagnosis, even though until recently there wasn't an ICD code, there was no standard, there were no blood tests, there was no way to prove that you had this. And as somebody who's also going through the process along with my staff members, I apply some of the things I've learned from science communication with our nonprofit to when I deal with folks who are not in our field or who are not having that firsthand experience. And I like to call it, there's a famous African proverb that goes, if a lion could speak English, we still wouldn't understand what it had to say. And that's because the frame of reference of the lion is completely different to our frame of reference. And sometimes that's where the breakdowns happen. And when you're in science communication, it's your job to figure out the frame of reference from one group and the frame of reference of the other group, whether that was the engineers who built the product and your students who they're on TikTok and their frame of reference is, you should be able to say it in 30 seconds or less. And how do you bring these two groups together so they understand each other? When I'm talking with individuals about trying to make sure my employees get workers' compensation, I find that empathy and storytelling that bridges that gap is my most effective tool. So fortunately, I can use my own story regarding why there would be a gap in proving that you got a COVID-19 infection, and there was an immediate cause and effect after that infection. I can give the example of, hey, look at my paper trail. Immediately, I called my mother, who's a nurse, immediately took my temperature, immediately called the doctor, all within an hour of me coming to in that bathroom. And my response, the response I received was, well, your lips aren't turning blue and you're able to talk, you're fine. And I had to explain that I was an African-American female. My lips will not turn blue, they will turn purple. But it took a week for me to have all of my paperwork in order to get a COVID test. We now know 30% of COVID tests given between February to May of 2020 were defective and gave false negatives. We also know that most of the individuals who got those COVID tests, it was a week late. And we know the time frame you have to get a positive COVID test to prove infection. So me being able to explain technically, because I know what they're looking for and what boxes to check, as well as giving a logistic functional example of, this is why there's a gap showing the direct cause and effect. However, we're both very logical. We like to say we're scientifically minded. What else would have been happening if there's a lockdown and they couldn't leave their house? Where else could this have happened? And given we have a staff of 7 individuals, you mean to tell me that 3 out of the 7 individuals just so all happened to go down at the same time with this mysterious illness? And we're going to pretend there wasn't a mysterious illness going through the community at that exact same time? And that's how I've been able to communicate. So there's ways, you just have to have the patience and fortitude and maybe a little stubbornness to figure it out. But I do think there's space for us to come together and address those things that Dr. Petrino mentioned.
And creatively and through innovative methods. So my last question goes to both Dr. Schrader and Dr. Vio. I think about internet technology, digital, the world, the gig economy, right? Part-time workers, right? The Uber drivers. I'm just wondering some thoughts that you would have, and we'll start with Dr. View, with regards to potential mitigating strategies that could be put into place, at a collective level to address the challenges for these individuals who are not, quote unquote, technically employed by an employer. They're either self-employed or they're part-time employees. And we know that, Walmart has a whole host of individuals that are part-time employees that are on public, benefits. So I'm wondering, from your vantage point of the healthcare disparities, what are some of the thoughts that you may have for the workers' comp world to begin to think about, to address in a holistic manner?
That's a really great question. At the Urban Institute, we had a convening about so-called non-traditional workers and other excluded workers, people who are at gig work or self-employed, all those things. So we talked about many of those challenges that folks who aren't traditionally employed or have that direct connection to the employer are locked out of a lot of these things and just didn't even have access to having unemployment or getting paid leave or any of those things. So for us in those discussions and for some of the groups that had attended that convening, what they talked about was the importance of having other benefits outside of employment. So we talked about the importance of universal paid leave or whether or guaranteed income, for example, or having an expanded health insurance option, having broader, more universal retirement, among other things. There's also different platforms that are available to support gig workers, especially those in electronic arrangements that are able to help them access certain benefits, regardless of their employment status. If they are self-employed, that helps them find different insurance options, for example, helps them with accessing different benefits. So that's one thing that we certainly discussed. Yeah, I think I would leave it at that for now. But that's definitely a concern because if you aren't connected to the employer, or even if you are working part-time, you don't have access to these benefits. So how do we ensure that people who are in those situations are able to have just as much economic well-being as people who are so-called traditionally employed or employed full-time?
Okay, thank you. Dr. Schrader, your thoughts on that?
No, there is so much for people to be able to manage and navigate in these systems. I think Dr. Petrino talked about this earlier, that it's really challenging. And, for people who are in precarious work situations, it's more so. So they don't have, employer-sponsored health care. They don't, as they're applying for disability leave, there's just all of these different systems, and having resources where you're not having to approach all of these different systems separately that can help you understand and effectively. I don't think that there's anything out there right now that can really support people to understand the various support that may be out there, or help them access that support. So, I don't know what that looks like. I think it's not easy to develop, but sort of a place, a one-stop shop where you could really learn about what's available out there to help you support yourself as someone who may not be in a traditional work environment.
Great, thank you.
Sorry, can I add something that I want to mention? I did want to say the Workers Benefit Fund is an organization that attended the convening that we had at the Urban Institute, and they were able to help build a bridge between telemedicine providers and Uber and Lyft drivers, so that they could access paid sick leave. They do support over 7,000 people in getting access to public programs like Medicaid and Children's Health Fund, among other things. So that was an example that I want to mention.
Great, thank you. And,
Dr. Kathuri, if I may, just
absolutely.
want to react to something very briefly. I'd be remiss if I didn't jump in on this one. Dr. Petrino mentioned the standard around having to prove that you were infected with COVID-19 at work. And, it seems to us, it seems to me in particular, that there's this disconnect between what we know as an insurance company, because we kind of live it on a daily basis, and what people may think on the outside. And I think the data is going to be illuminating on this. But the standard actually shifted. It changed during the pandemic. It's actually in our report. It's one of the footnotes where it was liberalized, where if you could show that you were working in a hospital, or if you could show that you were working in a grocery store, or if you could show that you were a bus driver, you didn't have to prove that you were infected at work. So that standard was liberalized. Now, having said that, I hear this all the time, that this is the standard, and people are very surprised when I say that this is the standard. So the prevailing view is that the standard's very harsh. It didn't change. You had to prove that you were infected at work. So one of the takeaways for us here as we have this conversation is to actually go out and do the outreach, especially with essential workers that may have been in this environment, to let them know that this standard shifted. It's not as burdensome as they might think, and that would expedite and get them to actually apply for these benefits and get them through the system faster. So I think just from one of the big takeaways from this conversation is just to kind of build that bridge between what we know and what people perceive as the standard on the outside.
Great, thank you. Very helpful, Gaurav. So thank you all. Learned a lot. This was really extremely informative, and the range of experience and vantage point that you all provided, I think this is really tremendous. We hope to be able to, bring you back together at a later date as we learn more, as you learn more and you educate us, and then we'll begin to disseminate this information through the wider community. I want to turn it over to Gaurav for some closing remarks, and thank you. Gaurav?
Thank you, Dr. Kathuria. Thank you to all of you. What an incredible dialogue. Just the depth, the breadth, the variety of topics, the variety of viewpoints, really enriching conversation. Just in terms of taking my notes, we've talked about health equity, we talked about treatment and access, macro labor market considerations, very impassioned and powerful personal experience during the pandemic and what's resulted from it. Gender and racial disparities, what employers can do to be supportive of their employees that are facing long COVID. A lot to digest. For us at NYSIF, as I've said before, this is a starting point. We've published a report. We plan to remain active in this space. We have more work to do, more reports to write, more of these conversations to have. We're incredibly fortunate to have this group that we can call upon for their expertise to inform our own thinking around what people are feeling around long COVID. So we look forward to doing that work, look forward to working with you in the future, and look forward to bringing you in on similar conversations in the future. Thank you so much for participating.